Our next speaker is going to discuss community engagement. This is Anna Zakowicz, who is working with the AIDS Healthcare Foundation in Europe and based in Amsterdam.
Hello, everybody. I need a second to prepare. I need some water. Okay. Hello, once again. Hello? Hello, are you with me? Hello! I know it's late. I actually would prefer to have a conversation, and I hope that the ideas I'm going to talk about will sort of spark some ideas within you. But before I start, well, why I'm going to talk about community engagement. First of all, I do believe in self-determination of a person, that we can choose what we want and who we are and what we do. And on the other hand, I also I'm the past co-chair of GNP+, which is Global Network of People Living with HIV. Right now we have two new co-chairs, fantastic Cecilia Chang, a fantastic, wonderful transgender woman, and Ryan Maduro, a man. And as I'm also from Europe, so I'm going, because we were talking about different continents. I'm going also to talk about different continents, but I would like also to give you some examples from Europe. But before I start, I have a question to you. So if you think, yes, I do believe, so please raise your hand, okay? Or you can shout, yes, I do believe, okay? Because we need to warm up. I think it's a little bit, you are a little bit tired. So who believes in community? Woohoo, bravo. Who believes in community-led responses? Yes. And who believes that community can self-determine what we want to have as healthcare? Wow, great. So why I'm doing this speech? And actually looking at what was happening today in the room, I think I was hearing a lot of people, probably 50% of the speakers, more or less, were talking about community engagement. But I think sometimes when we talk about community, I think sometimes when we talk about community, we talk about different things, because actually there are 60 plus different definitions of community. So today what I'm going to talk about is I'm going to talk about community-led structures and mechanisms that are used by communities. So by community members and community-based organizations. And to deliver the responses that answer the needs that affect the communities. And when I'm talking about community response, so I will be talking about the collective of community-led activities in response to HIV. I'm not going to talk about humanity, community as a whole, but when I'm talking about, I'm going to talk about services run by people who live with HIV or people who are affected by HIV. So I'm going to talk about different levels of engagement, advocacy, campaigning, policy change. I'm going to talk about community-based research, community-based service delivery, and I would like also to discuss community engagement and quality of care. And actually, right now, what is happening also at UNAIDS level, also at WHO level, UNAIDS is working on community responses to HIV. Actually, this work they've been doing it for quite a long time, but I hope that maybe when they finalize their work right now, when used by the broader world, it would be, it could affect community-based response. And also there is WHO work focused a bit on community engagement, especially in quality of care, and I'm going to talk about it. So looking at advocacy campaigning and lobbying, so I'm not going to talk about the history. We know that the community fought for access to treatment, for quality, for new compounds, how things need to be done. Well, here there are actually a few pictures from Europe. There is a picture from Ukraine, and actually there is a campaign by a patient group in Ukraine, and probably you've seen this slogan, Ukraine fuck corruption, because this is one of the biggest problems there, corruption in healthcare, not only in healthcare. We also have a photo of Silvia Petretti, who's here, who is a fantastic woman advocate. And also there's a recent campaign that we did in at the European Commission when there was a development, or there was a question if we are going to have continuation of communication for HIV or action plan in Europe. But we still have a lot of things to do because repression endangers the fight against HIV. We still talk about we need to fight for access to quality treatment for different populations because we know that they are treated as second-class citizens. We have coerced sex testing. Sorry, sorry. Wow. Loss of no confidentiality for those with a communicable disease, criminalization of behavior, and of HIV transmission. And of course, we are more effective in some areas than the others. And there are, for example, strong groups working on criminalization of HIV transmission. And Bernard is an example of, and Sean, who will be speaking after me, they really work hard on this issue. And as community, we're also working on concise guidance for HIV healthcare providers. This is a little bit different kind of advocacy, but so this kind of advocacy informs healthcare professionals what actually needs to be done for the patient to receive respectable treatment and care, and how should a person who comes for treatment and care, how should the person be treated? We also do research. We have community-based research, and it's done by mostly by the networks. And this is an example of stigma index that is done by GNP Plus and a network of women who live with HIV, and it's done at the local levels. And this research informed actually what is happening on the ground right now, also with concrete actions connected to country advocacy, but also development of people-centered services. Another examples of community-based research, for example, research within trans community to look at the issues that would help. Wait a second. That would analyze the factors that may include HIV transmission among trans women. There is research, for example, in Asia Pacific, looking at access to treatment. Is done by many treatment groups, also looking at stockouts and also looking at procurement. But this is, of course, done on everyday basis. And this one was actually a cross-sectional study asking about issues around access to treatment. We have some research that was done by sex workers and MSM communities. Also, Max Art study that was presented at this fora, where the networks of people who live with HIV were involved in the whole program. And I would like to focus mostly on community-based service delivery. And of course, I'm not going to touch every aspect of community-based service delivery, but I would like to talk about knowledge. I would like to talk about testing, of course, outreach, which is connected, outreach is also connected with knowledge and testing. And I would like to talk about clinical services that can be and are done by communities. Well, unfortunately, when preparing to the talk, I wanted to give sort of like a cascade of care, sort of like show where community-based organizations, where they are involved. But the thing is, the problem is, we don't have, as the community, we don't have very good information what is happening on the ground. And even communication between different organizations is based on like survey basis, so we can't really see what is happening. So I will give only a few examples from the work. This is an example of knowledge sharing, and this is an example of a fantastic program, Stepping Stones, that promotes gender transformative programming. And we know that it's not that gender transformative programming are these programs that change. Not only teach, but change the lives of women, but also the communities, because that's what we want. We are not talking only about women living in a certain community, but we are talking about the family and a village. And actually, this program was the only one that was systematically reviewed. And as they worked, they could see actually that people who participated in Stepping Stones were less likely to acquire herpes simplex virus, and then also they could see in some programs increased condom use. I think what we are talking about here in terms of knowledge is health literacy, and I do believe that it's a health literacy, or knowing actually what happens to you, is a major component of democratization of healthcare system. We need to know about treatment, adverse events, about quality, and we need to be our own advocates and also being proactive. And it's not only about HIV, it's knowledge is power, and also and then decision making. I will move now to testing, and my suggestion, which I probably repeat already, but not at this meeting. I do believe that we should change the way we test globally, and a few people were mentioning this, that we need to have community-based testing, but I think here, when we talk about community-based testing, we see a few models, because we have a model testing done at the community level and done by medical professionals. But I do believe that at this time, when we also have self-testing and then we have trainings, and we can really well educate testers, non-medical testers, this is really time to change legislation, and also different bodies that work on testing and guidance at country level, but also, for example, in Europe here at the European level, to really push for this, because we are still dealing with problem of huge number of people who do not know their status. And rapid test as a diagnostic tool, also in clinics, I think this is something to think of. And then, but for this, as I mentioned, we need to change the legislation. I would like to move now to the clinics, here, and yeah, I think at the last session, there was a mention about different kinds of models, and also people-centered model. I think what we need to do, we need to change how we think about a patient, and we need to move to people-centered comprehensive care. That the needs of the person are addressed, and then with the help also of non-medical staff, we can talk really about engagement and care. I wanted to give you one example from Europe, which is Estonia, and you know, Estonia is one of the countries in the European Union with the highest burden of HIV epidemic. So in the EU we have Estonia and Portugal, and of course when we talk about 53 European countries, we have Russia and Ukraine. But here this is an example of a try to address the needs of people who live in Narva, which is a tiny 60,000 people town on the border with Russia, 95% of people with Russian speakers, and huge percentage of drug use and very low coverage. And well, actually, what they looked at is also the Cascade of Care, so looking at the percentage of people who are virally suppressed, so it was 10%. So a lot to work on. So one of the initiatives was we meaning AHF Europe, we started working with the network of people living with HIV in Estonia, and actually what the network of people living with HIV did first, they did research, they did stigma index, and they really saw huge stigma and discrimination in the healthcare setting. And that is why they decided that one of the things that would be good to do is bring treatment closer to the patients. And the Linda Clinic, well, it was opened last year, mid-year. So the clinic has a license, medical license, and has a medical doctor who is licensed. So the clinic provides testing services, medical services, and also psychosocial support. So as you can see here, it's a really big range of psychosocial help, because the group who lives there really needs help with housing, with food, with helping with kids, and you know, basic things. Well, the problem actually that we account is that that we cannot be fully operational. Why? Because the clinic does not, because to be fully operational, apart from having a doctor, apart from having nice premises, friendly staff, we would like to have ARVs, but we do not get ARVs. So actually for months we discuss with the government, and well, we fight also with the government to get ARVs. And I think now, well, actually recently we had 2 or 3 weeks ago, we had a meeting with the ministers of social affairs, and it looks that they are positive, so let's see. But I would like to show you our cascade of care, because we have patients, we have 123 patients, and what actually happens, we test, and then we link to care at these facilities, and you can see that there is a huge difference between people who are retained in care and those who are on treatment, because people who are on treatment receive treatment in in other facilities. But anyway, they come for other support to Linda Clinic. So I would like to now talk about basics, because I do believe that, as I said, we we can self-determine what we want. And I do believe that patients are agents of change. And I do think that we who get services, we should be seen in this way. I know that it's probably scary, maybe a little bit revolutionary, or maybe not. But I think everyone is a patient in this or other clinic, and we all know that what we want and what our expectations are. And I think we need to change the paradigm from the 20th century, and it was mentioned already today that we need to talk about full engagement. And we need to talk really about, because it's not about competition, because I think maybe why this does not get through is that maybe healthcare professionals think, okay, so now we are going to compare each other, we are going to do studies who is better. Is it like medical health facility or facility with community engaged? I think it's not about this. It's not about competition. I think at the end of the day, we need to talk about collaboration, because I think this is the way people, and I think nature, this is the way nature acts. And I think we were taught to fight, but I think if we also talked a little bit more together and collaborate, things would be much easier. The next thing is respect. I think we need to get to the basics. We are all human beings, and respecting who we are is so important. And I think the first tiny step is just to shake hands and to show that I really appreciate and respect who you are. And it is lacking in many places where people access care. There was a study looking at relationship with HIV care providers and retention and care, and they looked at being treated with dignity and respect, involvement in decision about care, feeling listened to, having information explained, and feeling known as a person. And actually, participants who gave the highest ratings to their care providers, they rated being treated with dignity and respect as the highest. Also, careful listening was very important. Not so much decision about treatment. So I think still, again, we are getting to this issue of human being relationship. So the suggestions were that appointment adherence could be enhanced by optimizing the quality of relationship, listening carefully and explaining, and providers' communication. Another study, randomized study, looked at improving retention in care. So they looked at enhanced person contact with HIV patients, and they had 3 arms. One of them was standard of care, the other one enhanced person contact, and the other one person contact plus skill building. And the arms with enhanced contact and skill building, of course, showed that this is kind of intervention we need to look at. Well, it did not work so well for people who use drugs or people who had other unmet needs, but it means that it's important to, it might mean that it's important to address other needs, basic needs. Also, the World Bank looked so this is the report that was produced in 2013. They looked at community interventions and they wanted to see the results achieved at the community level. They wanted to identify areas where investment can achieve greater results, and look at policy and programmatic issues. So they focused on low-income countries, low and middle-income countries here. And I'm not going to give you all the findings. I think it's a very interesting document, but I think, unfortunately, it hasn't been very much publicized and very much talked about. Also in Africa, because I think if it was, I hope if it was, maybe the community-based interventions would be more supported at, for example, at a country level. So maybe I'll move to key findings on use of HIV-related services. So they saw that community response can increase the demand for health services, that broad community member and leader involvement can increase the demand, and that dedicated support is effective, and peer adherence support combined with nutrition can increase the timelines of scheduled hospital visits for ART. We all know these guidelines from 2013 and also 2014 guidelines for key affected populations. And in 2013 guidelines in operational part, there are two important for the community recommendations: task shifting and community-based testing and ART delivery. Well, as Meg was mentioning today, it's not really happening. This is actually a document that was prepared by GNP Plus, Alliance, and Stop AIDS Now, and I have it here. Actually, there are a few copies. I think if people are interested in community views on HIV, community guides to the guidelines, please ask me. But the last thing I would like to talk about is community engagement and quality in care, because as Meg was mentioning today, the next guidelines are going to include different additional parts, and one of them will be quality of care. And actually, I was very privileged to be at the meeting this week that worked. That focused, it was a scoping consultation, so like first meeting on strengthening quality of HIV clinic services. So the focus was the improvement in quality of HIV care. And as you can see, there are these issues that we don't talk very much when we talk about HIV services. So for example, process management or progressive management, or change packages to support healthcare providers, or social and cultural context. But for me, what is very important, that patient engagement and people-centered care is there. So I do hope that, probably not by PICO questions, because it will be very difficult to, as we do not have robust research, community research, to look how patient engagement in developing but also delivering HIV services, how it influenced improvement. I hope that we can do it in a little bit different way. And I wanted, because, dimensions of quality. I think here we are talking also about technical quality and experience quality. And this is, here it's important to talk about patient perceptions of quality of HIV and care. Because when we talk about quality improvement, actually we are talking about a model that was developed for car industry, and we are using it right now for health. But what is critical is to determine consumers' needs and to develop products that suit the needs of the consumers. I wanted I'm not going to lead you through the whole slide here, but when you look at the levels here, we see levels of engagement and partnership and shared leadership. So the far right on the bottom box, I think this is what we should aim at, which is patients have equal representation on agency committee that makes decision about how to allocate resources to health programs, and I would add how the programs look like. And there are community boards or advisory groups at clinics in the U.S. Also, there used to be there is a clinic actually for people who use drugs, with also involvement of people who use drugs. So I think this is what we need to aim at. And my last slide, I think we don't need to be we don't need to be afraid, and I think we need to change. And I think we don't need to be afraid of the word revolution, and it's not about changing everything, but I think we need to, as I said, we don't need to compete. We need to cooperate, and we need to think of clear steps what to do. So if someone has some ideas, I have some ideas. Please, let's talk in the evening. I'm sorry. That was so long. Sorry that I was so long.
Thank you very much. That was really wonderful, and hopefully there will be time for discussion.
Yes.
But I think now we should move on.